Pierre-François, Mr. Chairman, Mr. Co-Chair.
Inviting me to speak about this complex issue. And since it's a French society, and most of you are French speakers, I will do it in French because it's better than my English. Et donc je voudrais...
And so over the next 20-25 minutes, I would like to talk about endotoxins as one of the mediators or factors responsible for inflammation, and therefore try to see whether through methods that are supposed to be fairly specific, one can improve prognosis for patients when you remove endotoxins. Endotoxins are nothing new. They are part of a sepsis jigsaw puzzle that's very complicated and that has not been simplified over the last few years. Here you can see all the important parts, and if you take all these aspects into account, not one more than any other, you can hope to change the outcome, the prognosis for patients, once you've taken all the known notions into account. And there are many more being found every day coming from the negation of previous notions. People say that this is not what you should think anymore, you should think that. And so our young colleagues are rather lost. The old colleagues are not lost because they no longer play this game. And in my experience, I've seen a lot of things. You should do that. And very often it's not that bad. It's not necessarily based on very strong measures, but experience goes a long way in intensive care, although it's extremely exhaustive. So this is a slide that I took from Steve Opper. It's a simple process. I've shown you this to relax you. However, you can see that if on the y-axis you have time, in fact, the endotoxin or lipopolysaccharide starts immediately, and it immediately generates response, because if there's no response, you don't know that there's the endotoxin. And that's why I discussed it before with you to say that detoxifying, remove, neutralize, but our system already includes that. There are already things that are going to bind the endotoxin to avoid a constant disaster. So it already exists. And since this system that we have, when the system that we have in our bodies is overwhelmed, then the war starts. But you come after that, it's too late. And then you can say, well, I'll take preventive measures against terrorism, right? But for your current patient, it's too late. Everyone's dead. And here it's difficult to say that I'll take preventive measures for risky patients. But maybe that's the way you should go about the situation. At-risk patients, enhance preventive treatment, and with that maybe will avoid disasters in the future. Peritonitis is not very complicated. Here there's no discussion. Well, for Catherine it was difficult. Pancreatitis, inflammatory disease which may become infected but not necessarily. You have inflammation that's not septic, that may become complicated with septic inflammation. Here this becomes tricky, because when you go from one to the other, when should you treat or not? Intellectually it's difficult, but I'm a basic guy. If there's a hole in the gut, well, I'll operate. And when in Canada we had that, we'd said, well, you need to go there, and then we went there. It's not surgical indication, controlling the infectious focus. It's easy, you need to go and take a look. And here in 2014, I journal that I don't quote every day, Langenbeck's Archive of Surgery, A strong, sturdy journal said intestinal perforation is called secondary peritonitis. It's not primary. There's a hole, and it leads then to peritonitis, and mortality maybe around 30%. When I started studying medicine over a century ago, mortality of peritonitis was announced as being catastrophic. The notion of catastrophic a long time ago was 70%. Now that's 30%, and it may be way less than that, because 30 is what you get from the databases, but it may not be so high, obviously. But here, this is a paper from 2014 saying that it's 30% for peritonitis, but when there's septic shock, it goes up to 60%. Well, here, I'm not sure about that. I don't know where the shock comes from, but I'm shocked about their shock, because it's not 60%. And I'm sure that in your hospitals, if you look at your databases for septic shock with peritonitis, it's not 60% death. They explain that you need to drain, have a laparotomy and a second laparotomy as soon as possible whenever you're in doubt. I won't explain that, you know that better than I do, so I won't dwell on this. In 2009, already 6 years ago, the data were collected, and Florence and the group looked at peritonitis in our hospital to see what happened and see what were the factors associated with mortality and see what was the death rate for these patients who had peritonitis. Out of 180 consecutive peritonitis collected with great care, as an extremely accurate and precise female intensivist would do. A guy wouldn't be able to do that, but out of 180 patients, she found 41% of patients with shock, less than half. Overall mortality, if you take everyone, shock and non-shock, was 20% 6 years ago. And if you have shock, the mortality rate is 35%, so very far from the 60% in the 2014 German publication. I don't know, maybe we don't have the same type of patients, or the air is better at Lariboisière, but we have half their rate. That's a big difference. And for those who have peritonitis without shock, mortality was 8%. So therefore very low, and I think that it's closer to your daily realities. One thing is interesting. Mortality, we had this notion that peritonitis, that was a complication for surgery, had a less good outcome than community-acquired peritonitis, but according to our data, there was no difference in outcome between community-acquired and post-op peritonitis. There's nothing new here. It's probably better to be healthy, young, and rich to not be in the database of severe patients. When it's severe, you're less wealthy, less beautiful, less everything. And the more severe it is, the more you die. Well, you'll have learned something this morning, probably. Elderly patients die more than young people, and we see fewer young patients because they have less peritonitis, so it's a bit more complicated. Microorganisms. There are microorganisms that seem to be, statistically, there's no mechanism associated behind it. They seem to be associated with higher mortality, especially the presence of anaerobes, and I know that it's difficult to recover anaerobes in perioperative samples. You need a motivated lab for that, and it's not always the case. They may have other things to do, but here it was fairly well diagnosed, and you see that every time when you have a lot of predominant anaerobes in the culture, there's a higher risk factor. And it's the same for fungal or yeast infections. It's not a good situation either. One thing that was interesting in this work, for gallbladder peritonitis, everyone knows that, but we don't encounter that very often. Biliary peritonitis as a specific notion has higher mortality than other cases. You can see the very significant difference between the two. Having biliary peritonitis is bad. You double the mortality level. And we don't have a lot of epidemiological data that are specific to biliary peritonitis. Here you can see the bacteria associated with the differences in the presence of shock or not. You may say that these are more aggressive bacteria, Enterococcus, anaerobes, fungus. And here there's a significant difference in the presence of shock. If you're polymicrobial, this means that there's one that grows predominantly. Everyone has several microbes in the digestive tract, and there's one that grows more. So with one predominant germ or several that grow predominantly. And if it's gram-negative, it's bad for patient outcomes. There's one notion that's very important that you don't hear much about: the quality of surgical care. In all papers, you go to the OR as if the OR was surgery was always good. Surgeons are always perfect. Intensivists always wonder whether they should push this or that vascular filling on whatever, this or that. We keep searching our souls, and that's a good thing, but surgeons don't really do that. Is the first semester, sixth semester, interns, the head of department, the result would always be the same, whatever the surgeon? Well, of course not. And you never hear about that in the papers because it's a very bad thing and it's very badly seen by reviewers. We experienced that very severely with the team that worked on Abdomix. We tried to be as candid as possible to assess the quality of surgery in the clinical report, have it assessed by an independent surgeon. Wow, my God, that was very badly received by reviewers. But if you have adequate surgery, mortality goes from 27 to 13. Here it's not. Surgery from 90 to 20, I don't know. Or maybe the anesthesiologist was doing the surgery, 25 to 10, 47 to 14. It's clear that when surgery is done right, you improve patient outcomes. And that's something that we should look at in our environments, because if you change the department head or the deputy head, things become catastrophic. That's the same surgery. You open the belly the same way, the same viscera and so on. Lavage. In your patients, you write down the number of liters used. By young surgeons nowadays, they don't really like to stay in the OR for very long. I don't know whether they like to go to the OR because they do whatever they can not to operate. They want CT, another CT, get that. Oh, no, not really. Let's wait a little. So patients die without getting surgery. That may happen. And so they are not so interventional. And that's a bit of a problem because it's essential to know whether young surgeons can do things right or not. And there's time to intervention in peritonitis. I think that nowadays motivating surgeons to operate on patients with peritonitis takes some time. 15 years ago, straight to the OR. Now they'll get a CT. Are you sure? Maybe. What if my aunt? I don't know. Let's go. And once they're in the OR, they'll push 10 liters, shake a bit, 15 liters, lavage, and you should have 30 liters. Well, 30 liters at 3 a.m., that's exhausting. Young surgeons are exhausted. I infer that they're always exhausted. There's no evidence in the literature about delayed surgery and the consequences on patient outcomes. There are very few papers about that, but that's very important. And in the next session, you can hear about golden arrows. I don't know whether the golden arrows in sepsis are important, but golden arrows in non-surgery are not important. Here I don't understand, so we'll need to really urge surgeons to work in greater cooperation. They do a lot of things well, surgeons. They take things from intensivists, they copy, and then they add surgery to the mix. Well, here you have golden arrows. Source control, as you can see here. You can operate at any time, but this is not where it's happening, because they say you should push antibiotics in the first 8 hours, and then a small stay in the ICU to get the patient right. Good luck. And then you go to the OR, surgery, and then the patient's saved. Believe you that. But in peritoneal infections, there are endotoxins. Gram-negative equals endotoxins, and the more endotoxins, the more serious it is. And the more gram-negative germs you have, and that's nothing new. Where do endotoxins come from? Well, from wherever there's translocation that's possible. You may have overexpression, overgrowth. You may have translocation from the digestive tract to the blood through the peritoneum, and the peritoneum may not be very efficient. The peritoneum is very efficient. It's great cleaner. And you put that in the brain during a stroke, you take a bit of that, you put that on the brain, and it cleans the brain that was necrotic. It's been published, so it's good. It's a great cleaner. Endotoxins, you inject them into animals. For 20 years, you've read papers saying that endotoxin models, you know, Mr. Payen, it's very different from sepsis. Okay. But what should look at that is cecal puncture. It's very good. But what's the difference? There's a cecal puncture, but it's to get bacteria across that are loaded with gram-negative and that will produce endotoxins. I can't really see the difference. The difference is between severe acute inflammation and that will lead to sepsis. If I give you a strong bolus of endotoxins, how long will it take you to clear endotoxins from the blood? You'll answer 5 minutes, 1 minute, 1 hour. Who votes for 1 minute? 1 minute, 5 minutes. Hey, you have to vote. You have to vote. This is democracy. Enjoy it. It won't last. 1 minute. 2 minutes. 5 minutes. 5 people. 1 hour. All the rest. 40 seconds. If you inject the endotoxins, 40 seconds later, they disappear. Wow. So you need to remove the source, that's true, because otherwise you'll have endotoxins constantly. But the bolus, you've got extremely powerful systems. Don't believe that you're constantly exposed to the presence of endotoxins in the blood. That's not true. When there are no endotoxins in the blood, which is never the case, there is no gram-negative infection. And people explain that it's very important. John said that. Sensitivity 85%, negative predictive value 97%. That's what we're interested in. No endotoxins, no gram-negatives. And people say that, oh, they keep falling, these mic protectors. And so people say you should assay endotoxins. Do you do that? Who does routinely? Great success. You don't have endotoxin assays, and that won't happen in the future. I tested this. I think you've already tested it out. Well, it's delicate because in gram-negative infections that are documented, sometimes no endotoxins were found, and in abdominal staphylococcus and infections, endotoxins were found. Okay, life's complicated, but endotoxins lead to inflammation, especially through the activation of the toll-like receptors and the binding with CD14. You know, this great complex, that's very important, but that's immediate. So I don't see how when you come after the fact you'll be able to cure the patient once the deal is already done. If you want to do something against endotoxins, you should be there slightly before the war. The police waiting for terrorists. That may work. Once after the shootout, you can arrest the terrorists, but the people are dead. That's the idea behind it. So let's purify the blood. Let's purify ourselves, dive into the Ganges, which has chock full of endotoxins, by the way. I took samples, so I can tell you. There are membranes that remove all that's bad, activated cells, so all cells. Endotoxins, good luck. Cytokines, but what kinds of cytokines? All of them, some of them. What's good, what's bad? One thing that could be good one day would be bad the next day, and vice versa. But anyway, we have a membrane that removes endotoxins. Alhamdulillah. And so this membrane is a high-tech membrane that's very well done, that chelates endotoxins. It's loaded with polymyxin B. Polymyxin B is going to bind the constant part, which is the lipid A. All the rest of the endotoxins are extremely diverse. You need to fix the lipid A. For those of you who are not so young, and Francois, you're very young, but you were very precocious, and you'll remember the famous Centocor, which chelated endotoxins by binding to the lipid A. And people said it saves lives. 20,000 francs at the time. We still had francs back then. So you had your ampule at 20,000 francs and you wondered whether to use it or not. Okay, I'll push it. And then there were 4 consecutive studies after the first one saying that it didn't work. Why didn't it work? Because the antibody wouldn't go onto the lipid A. So, have it back. It wouldn't bind with the lipid A because the hairs around the endotoxin protected the lipid A, and so the antibody did not necessarily bind to the lipid. And so it worked very inconsistently and it became outdated. But here they explain that when you use the cartridge and see what happens with the cartridge that chelates the endotoxin, ex vivo endotoxin levels drop. The cartridge works, no doubt, and in patients, apparently it may reduce the level of endotoxins in the patient. So there's evidence saying that it's good. In Jean-Louis' trial with Jonathan Cohen, with the improved Limulus test, there was a drop in endotoxins. But what I didn't quite like is that at the beginning they had 73 in one group and 28 in another group. That's a bit of a problem. 28, 29. At the end of the day, there are fewer, but there were fewer at the beginning. What mattered here was the baseline, and there was no difference for IL-6. Disappointing. IL-6 is a marker of inflammation, did not drop either when you use the membrane. So not clear for endotoxin and not clear either for inflammation. There were a lot of studies outside. All our Japanese friends were all here, and there's only Vincent who wasn't Japanese at the time. But Tanaka Vincent was not yet born. He had a randomized trial and he found no difference in mortality, but still a benefit in terms of hemodynamics. It seemed to improve mean arterial pressure, which seemed to advocate for the use of the membrane, but 8,000 euros per treatment, 8,000 euros. There was a drop in the euro, but it's still significant. So Dr. Cruz conducted a meta-analysis published in JAMA the UFAS study with 34 and 30, so 64 patients randomized into 2 arms. 64 is not a lot. JAMA, 64 patients randomized. Great. It was published in the JAMA because they're similar for everything, and here you have mortality, which improves in the group treated with polymyxin. 41%, that's better than our septic shock, versus the control arm, 66%. Well, here, I don't know where that figure comes from, but it wasn't designed for that. But in the post-hoc analysis, there was a benefit in terms of mortality. Everyone said that, yes, we have a drug for the endotoxin, so we need to use the molecule. Here you can see mortality 32.53. That's not small. That's a big effect. It's significant. And so we tried to redo this trial because 65 seemed a hard figure to extrapolate from. That was great, but you couldn't extrapolate that to the whole world. 7 billion people. That seemed to be a broad extrapolation. So we did a study with French centers. It's a French study. That's a limitation, I admit. And Payen is an anesthesiologist, so it's not very good. And Robert is a medical intensivist. We did that. Everyone was great, very professional, very thorough. This trial was conducted seriously with patients with peritonitis who received 2 cartridges. The JAMA reviewers who refused the paper said, "Why 2 cartridges?" Well, because we were said it should be 2 cartridges. Well, what do the others do? They have 2. Yes, okay. I'm outraged by what I read. But anyway. We tried to limit heterogeneity between patients, only perforated peritonitis, and we assessed the quality of the surgery. We looked at 28-day death rate because that's the standard. We looked at D7, D14, and 90-day mortality. We looked at whether it improved organ failure. We looked at the number of free days for cardiovascular, respiratory and replacement, renal replacement therapy support, whether comorbidity was improved, the quality of surgery, the fact there was high systemic inflammation, IL-6 was high or not, and we tried to do everything right. We included the people who wanted to be excluded. We excluded those who were dying, pregnant women, and so on. We tried to do it fast. So from the time of diagnosis after surgery, we gave ourselves 2 hours to avoid a propofol shock. They still need noradrepan, and it was randomized into 12 hours after surgery. Then there was 1 session with membrane, and then second membrane, and see what happens. 119 in the membrane group, 113 in the control group. We didn't lose anyone in 90 days. In terms of information, we lost a few patients, but that's normal, if I may say. They were similar for all characteristics. I won't bore you with that. René will make a detailed presentation on Friday. They were similar. Shock with noradrenaline, norepinephrine, 64-65 JAMA reviewers asked why it was 65. And everyone got norepinephrine. That was an inclusion criterion. Why norepinephrine? Because it's a definition of shock. Fluid therapy, we even included fluid therapy that wasn't in JAMA 2009, but that was in our proposal. They turned it down, too much fluid. IL-6, same thing, very high. Okay, but your values are too broad for IL-6. Why? So Payen's really outraged, the speaker says, and mortality intent to treat. Here, this is cumulative mortality. The higher it is, the more you die. The full curve is with the membrane, and the dotted curve is without the membrane. And you'll see that with the membrane, it's not significant, but it's above the curve without a membrane. So at the end of the day, it does nothing significantly, and if there was a small doubt, it would be worse. Golly. At day 3, day 7, day 14, day 28, Day 90, each time it's not significant. Per protocol, same thing, no change. High comorbidity or not, impact of surgery well or not conducted, no change. Adverse events, no difference between the two groups. So to conclude, in the current state of affairs and the timing that we did that, it may be even better before that or before surgery. The use of this treatment is not beneficial to reduce mortality in peritonitis with shock. Thank you so much for your attention. Pierre-François.